this teaching activity is on interstitial lung disease. The objective of this activity is to describe the classification, etiology, presentation, and diagnostic evaluation of interstitial lung disease. So what are interstitial lung diseases? How can we define them? Interstitial lung disease is not one specific condition, but it's a term used to refer to a heterogeneous group of diseases that affect the pulmonary interstitium. This term typically excludes infectious diseases like tuberculosis and neoplastic diseases. Pathologically, interstitial lung diseases are characterized predominantly by inflammation and fibrosis that is seen in the lung interstitium. In addition to this, there are alterations in the alveolar and airway architecture. The interstitial lung diseases are all associated with pulmonary function studies that indicate a restrictive pattern of lung disease. So how are interstitial lung diseases classified? There are many different ways of classifying interstitial lung diseases, and this is one way of classifying these diseases. There are exposure-related interstitial lung diseases secondary to connective tissue diseases, idiopathic interstitial pneumonias, and other interstitial lung diseases. So what are the exposure-related interstitial lung diseases? These are interstitial lung diseases that are associated with exposure to certain substances. So there's hypersensitivity pneumonitis or extrinsic allergic alveolitis, which is a group of interstitial lung diseases that occur due to exposure to organic substances. Then there are the pneumoconiosis, which are interstitial lung diseases that are caused by inhalation of inorganic substances. Then there are interstitial lung diseases associated with exposure to radiation or radiation pneumonitis, and medication-induced interstitial lung diseases. So the hypersensitivity pneumonitis, as I mentioned, are due to exposure to organic substances. And these diseases are not named according to the substance, but in fact, according to the occupation of the people who tend to develop these diseases. So we have farmer's lung, which is associated with exposure to moldy hay, and bird fancier's lung. Then pneumoconiosis associated with inhalation of inorganic substances include exposure to coal, resulting in coal worker's lung, exposure to asbestos, which can result in asbestosis, exposure to silica, which can result in silicosis, and exposure to beryllium, which can result in berylliosis. So these are all occupation-related diseases that cause these pneumoconiosis in general. Then the medications that are associated with interstitial lung disease include amiodarone, which is an antiarrhythmic, nitrofurantoin, which is an antibiotic, and methotrexate, which is a immunosuppressant drug that is used in the treatment of connective tissue diseases. So in addition to exposure-related interstitial lung diseases can occur secondary to connective tissue disease as well. So these diseases are systemic sclerosis, rheumatoid arthritis, mixed connective tissue disease, polymyositis, dermatomyositis, and SLE. So we will learn more about these diseases in your musculoskeletal module. But remember, in addition to involving the bones and the joints, these diseases can also affect the lungs and result in an interstitial lung disease. Then there's the idiopathic interstitial pneumonia. So this group of diseases have many overlapping features, and they also have certain clinical features and distinct pathological features, which when put together can help to come to a diagnosis. So the terminology of this group of diseases is sometimes confusing. There's idiopathic pulmonary fibrosis, which histologically is associated with a usual interstitial pneumonia pattern, non-specific interstitial pneumonias, cryptogenic organizing pneumonia, respiratory bronchiolitis, interstitial lung disease, desquamative interstitial pneumonia, and acute interstitial pneumonia. Then there's the group which form the other interstitial lung diseases. These include sarcoidosis, vasculitis, which associated interstitial lung disease, which can be seen in granulomatosis with polyangiitis, which was previously called vaginous granulomatosis, eosinophilic granulomatosis with polyangiitis or Churg-Strauss syndrome, and eosinophilic pneumonitis. So this table sort of summarizes the classification of interstitial lung disease. And the two highlighted with the asterisk, respiratory bronchiolitis, interstitial lung disease, and desquamative interstitial pneumonia occur almost exclusively in smokers. Right? So that's important to remember because the clinical information can be useful in coming to the diagnosis. So we've discussed the classification and the etiological factors of interstitial lung disease. So how do these diseases present typically? So interstitial lung diseases are chronic diseases. So they present with symptoms of subacute or chronic dyspnea. So we said that there's typically inflammation and fibrosis in the lung in these patients. So the main symptom is usually dyspnea, and this dyspnea or difficulty in breathing is usually progressive. And there may be an associated non-productive cough. And in a patient presenting with productive long-standing dyspnea with or without a productive cough, we need to think of an interstitial lung disease, particularly if they have a history of occupational or animal exposure, connective tissue disease, chest irradiation, or use of an medication such as amiodarone, nitrofurantoin, or methotrexate. So dyspnea is one of the main symptoms. There may be an associated productive cough. These patients are usually hypoxemic, and on examination of the lungs, there might be fine crackles. So fever is seen in hypersensitivity pneumonitis and sarcoidosis, but is otherwise an uncommon symptom in these patients, unlike in infectious diseases where fever is seen often. Clubbing is generally only seen in advanced idiopathic pulmonary fibrosis. And in these patients, we always need to look for extrapulmonary symptoms or signs, because remember, they can be associated with systemic diseases like connective tissue diseases and sarcoidosis and vasculitis. So if we do see these extrapulmonary symptoms or signs, then it's more suggestive of one of these conditions resulting in an interstitial lung disease. So dyspnea and cough are seen in ILDs, but wheezing and hemoptysis are uncommon symptoms. So how would we investigate these patients? So one important aspect is looking into the exposure history, because a large group of these diseases are associated with exposures, and then diagnostic tests. So in your exposure history, you'll ask about current and prior occupations, you'll ask about hobbies and exposure to animals, type medications that have been taken, like amiodarone, nitrofurantoin, history of illicit drug use, such as use of marijuana, and a history of prior irradiation. So what are the diagnostic tests that are useful? Chest X-ray is helpful. Lung function tests will show a restrictive pattern of lung disease. A high-resolution CT is often done in these patients, and particularly if the patient is deteriorating rapidly or you need urgent diagnosis, lung biopsy and bronchoalveolar lavage are useful. So this is a chest X-ray from a patient with interstitial lung disease. The changes seen are typically bilateral, and there's fibrosis in the interstitium, and as a result of that, there might be small nodules, irregular lines, or a ground glass shadowing seen in the chest X-ray. In the long term, this results in diffuse scarring of the lung and a honeycomb appearance, which again may be visible on the X-ray as well. And eventually, as a result of the extensive pulmonary fibrosis, there's pulmonary hypertension, and that can result in right heart failure and cor pulmonale, where there is heart failure secondary to a chronic lung disease. On the chest CT, high resolution CT, there's honeycombing of the lung, which we are seeing here. And that's characteristic of advanced interstitial lung disease. This is a high resolution CT from a patient with advanced idiopathic pulmonary fibrosis. So pulmonary functions tests, as I mentioned earlier, there is interstitial fibrosis. So particularly these tests show a restrictive pattern as a result of the reduced FVC or forced vital capacity. The FEV1 is normal or reduced, and therefore the FEV1 FVC ratio is either normal or increased. There's lung fibrosis, so there's reduced lung volumes and a reduction in total lung capacity, and also there's reduced diffusing capacity. So pathologically, the gross changes in the lung in interstitial lung diseases can vary depending on the severity of the disease and also the underlying etiological factor, but all will show fibrosis. This is a lung from a patient with advanced idiopathic pulmonary fibrosis, and you can see there is extensive fibrosis of the lung. Microscopically, also, the specific changes differ according to the severity of the disease and the cause, but the histological features can be helpful to confirm the presence of fibrosis in the lung and also to determine the cause. But we always need to correlate the pathological changes with the clinical and radiological features. So this is a lung from a patient with idiopathic pulmonary fibrosis. So typically the fibrosis seen here, which we can see in this part of the lung, there's no lung. Now here we are seeing normal lung tissue, but here the normal lung tissue is obliterated due to the fibrosis. This is the pleural surface. So the fibrosis here tends to be subpleural, and idiopathic pulmonary fibrosis is patchy. There's often subpleural involvement, and there are these fibroblastic foci that are seen. So this is another fibroblastic focus that is seen in idiopathic pulmonary fibrosis. So the histological changes seen here differ from the other causes of interstitial lung disease, but you don't really need to worry about the specifics of the individual entities. So this is just to show you some examples of the changes that can occur in the lung. So coal workers pneumoconiosis is another example of a disease that can affect the interstitium. So this is seen in exposure to coal, and there's pigmentation as a result of the carbon, and the lung has undergone fibrosis, and there are black plaques which can range in size from a few centimeters to up to 10 centimeters. And microscopically also we are seeing fibrosis in the lung with the black pigment. So most patients exposed to coal do not develop this severe degree of fibrosis. There may just be anthracosis or pigmentation in the hilar lymph nodes and along the lymphatics. In more advanced cases, there may be some fibrosis, which we call coal workers pneumoconiosis. But sometimes the disease can be extensive and there can be progressive massive fibrosis or complicated pneumoconiosis. And silicosis is another occupation-related interstitial lung disease due to exposure to silica. Here we are seeing blackish nodules in the apex and other parts of the lung as a result of the fibrotic reaction in response to silica. And there are these fibroblastic foci on microscopic examination. Another thing to remember about silicosis is it is associated with an increased risk of pulmonary tuberculosis as well. Then this is a lung with sarcoidosis. So sarcoidosis is another important cause of interstitial lung disease. So in addition to the lung, sarcoidosis is often associated with enlarged hilar lymph nodes, as we are seeing here. There's inflammation in the lung, and there's granuloma, which we are seeing here, and there can be healing with fibrosis. So another example of interstitial lung disease. So you will realize that the pathological features of these different types of interstitial lung disease vary widely depending on the cause. So we always need, particularly when you're dealing with an interstitial lung disease, to take into consideration the clinical history, examination findings, particularly the presence of extrapulmonary signs and symptoms. Then we need to look at the radiology, and if a biopsy is available, correlate it with the histology before we come to a diagnosis. So to summarize, we think of an interstitial lung disease in a patient who presents with subacute or chronic progressive dyspnea and or non-productive cough, particularly if they have a history of exposure or a connective tissue disease. So remember, dyspnea can occur due to various conditions. It's not always due to pathology in the lung. Heart failure can cause dyspnea. But remember interstitial lung disease as one of the differential diagnoses in a patient presenting with progressive dyspnea. And especially think of this if there's a history of exposure or history of connective tissue disease. On examination, the patient is hypoxic, so has a low SpO2, and there might be fine crackles on auscultation of the lungs. Chest X-ray will show reticular nodular shadows and might show ground glass appearance, which can also be seen on a high-resolution CT, which is the imaging of choice in these patients. So on high-resolution CT, again, there might be ground glass appearance and honeycombing of the lung when the disease is more extensive. But each of the specific entities that we discussed will have specific features on radiology, which will point to the diagnosis as well. But these are the general features that are seen. The pulmonary function tests are not useful to distinguish between the different types of interstitial lung disease, but they will all show a restrictive pattern of lung disease, and that is useful to confirm that there is in fact an interstitial lung disease that is going on, but it doesn't help to identify what the specific interstitial lung disease is. So what is useful to come to a specific diagnosis of the cause? So one thing is the clinical history, the time course, the history of specific exposure, either occupational exposure to organic or inorganic substances, a history of exposure to radiation, drug history. So those are useful to identify the specific cause. Then a history of connective tissue diseases, smoking history, because certain interstitial lung diseases are seen exclusively in smokers. Then examination, the presence of extrapulmonary physical signs. So we said sarcoidosis is a disease that's associated with interstitial lung disease. Then your connective tissue diseases like rheumatoid arthritis, SLE, systemic sclerosis are associated with interstitial lung disease. So these patients need to be examined to look for these extrapulmonary physical signs. Then the CT features can be useful. There are specific features on the CT that can occur in the specific interstitial lung diseases. And then sometimes a bronchoalveolar lavage or biopsy can help in the diagnosis, but is not diagnostic alone. And remember, pulmonary function tests are useful to confirm the presence of an interstitial lung disease and to assess the severity, but they cannot distinguish between the specific causes. So there's a small quiz on the LMS for you to try to answer based on what you have learned in this short presentation. And if you have any questions or feedback, you can drop me an email. Thank you very much.